We've had the supersonic now for over 6 years, almost 7 years in the office. It's less expensive than the FibroScan, and it's better equipment, and your time to pay off the equipment is 1 year. We with the ultrasound, we actually a lot of times we're getting more payment for ultrasound coding than we are for the actual clinic visits. I mean, I might get $130 for my clinic appointment, but I'll get $220 or $240 for my ultrasound appointment. So we don't like to get things bounced back. We want to transmit our clinic note that has our ultrasound report with it once to the insurance company and get no dingbacks and get it paid. And we found out that they accept the transabdominal ultrasound code every time. Probably about a third of the referrals now to GI doctors are due to either abnormal liver function tests or abnormal imaging of the liver, i.e. fatty liver or nodular liver, rule out cirrhosis. And so any gastrologist who wants to be competitive in the market is, got to be able to tackle those issues with the patient. And if you want a quick answer on that patient, abnormal imaging, do they have cirrhosis? Yes or no. Do they have fatty liver? Yes or no. You need the shear wave. And it's very easy to incorporate. A lot of gastrologists already do endoscopic ultrasound. And so incorporating ultrasound in their office is a pretty easy transition. But what moved me into my practice is that, I do all the follow-up ultrasounds now for my cirrhotic patients. And that was because I was getting so frustrated. I was sending my patients to the hospital or a hospital-based ultrasound unit, and the reports are coming back, poorly visualized liver. And these are quotes, poorly visualized liver. And that patient with cirrhosis is counting on an ultrasound that could visualize the liver, right? And so we don't have that issue anymore. There's no, we have 100% visualization of the liver. And, it's very frustrating. We like to look at the portal vein on all our cirrhotic patients. And the hospital goes, well, you need to order Doppler with that ultrasound. To me, it's like when you're a gastrologist, that's just, you don't need an order to do that as part of the comprehensive evaluation of a cirrhotic patient every 6 months. So it's
right,
because we do over 400
join the meeting,
a year now in our office, and they're good quality ultrasounds.
Okay.
And the beauty is when you've got the supersonic with you, you've got an image of the liver, and you can, if you got irregular borders of the liver, if you got a macronodular liver, it's very coarse and heterogeneous. All those features you get on with a supersonic machine, you don't get those with the FibroScan.
Right.
If you got that makes you feel comfortable that you can disregard the FibroScan, false security reading, whereas the shear wave you can trust because you've got an ultrasound image showing all these features of chronic liver disease on the severe side, and then in the shear wave goes along with it. So what I like about the shear wave is I will, and this is honest God truth. I mean, if I've got a coarse liver, irregular edges, blunted edges, and I've got ascites in my KPAs, let's say 16, I'm going to say cirrhosis, right?
Mm-hmm.
But if I got a liver that's just fatty and it's got a smooth edge and it's just, there's no ascite, I mean, that 15 is not going to be an F4 for that fatty liver. You know what I'm saying? So I am sort of putting the big picture together.
Right.
Incorporating more than just a number. It's a number plus my ultrasound image.
Yeah. Okay.
To give me, and that's something I don't think is. I think they really dumbed down the KPAs. They're very helpful, but I think that's the beauty of your machine is you can put the whole picture together.